So it's a pleasure to be here. It's remarkable that you got together all the people who are interested in breast cancer care. And I know these are trying times for your country. And for all of you to come and continue your medical education at such times is impressive. And I thank you for being here, and I'm happy to be part of this conference. I have two talks this evening. The first is about nipple-sparing, skin-sparing, and skin-reducing mastectomy with immediate reconstruction, and I'll be happy to share with you some of my experience. So, most of you, I assume, are general surgeons. And the first question, I guess, is what not to do when you're doing a mastectomy for a patient that might consider breast reconstruction either immediate or delayed. I must say that in the last 10 years, my practice has changed completely from being 90% delayed breast reconstruction to being 90% immediate breast reconstruction. So we see much less delayed breast reconstruction, and in that sense, the better material you leave us with, the better job we can do for that patient. I think it's a good idea not to extend the scar beyond the mid-axis of the breast, and you'll see why in a minute. You don't have to excise all the excess skin on the breast. Most of it will at first contract and then soften and be a good start for any surgeon at any time to do a breast reconstruction on this patient. I think keeping the inframammary fold is very important for immediate or delayed reconstruction. You should keep it. And finally, the sutures should be as well as possible within the confines of your scar. These are some examples of patients that have scars that are not very easy to deal with, and there's no reason for the skin excision to be as wide and the scar so long entering into the cleavage of the patient. And to top that, this skin sutures that are placed outside the wound will stay there forever. You would like to make a scar that the next surgeon can ignore and either use it or not use it and so on, but that should not be an ugly signature of yours on the patient's breast, because it stays there forever. These were given to me for this conference by Dr. Kaplan, who is a colleague of mine in Tel Aviv, who is doing very nice breast reconstructions, and he's using this transverse ellipse. Obviously, he does very beautiful breast reconstruction, except for the fact that every time you put an ellipse in the center of the pyramid of the breast, it will go on to do two things. A, it will go into the cleavage, and B, it will flatten the breast, so it will give you a square breast. These were sent to me by my first resident, Dr. Becker from the United States, who also does very small ellipse at the center, the peak of the breast cone. And he gets those kinds of results, which are good, but a flattened breast. This, on the other hand, is a patient of mine where we hoped to do a skin-sparing mastectomy through an incision on the lateral side of the breast, from which we do the entire mastectomy and the axillary sentinel node dissection. We couldn't preserve the nipple because doing a biopsy from the base of the nipple at the time of mastectomy, there were cancer cells in the base of the nipple, so we removed the nipple. Even though we removed the nipple and put a tissue expander there because we were doing a breast augmentation on the other side, when you look at the patient in the center with a tissue expander and on the right with her definitive implant before we did the nipple reconstruction, you can see that the scar, while long, has now gone higher and it doesn't go into the cleavage of the patient. If there's one operation that the word teamwork is crucial, it's breast reconstruction, mastectomy, radiation, and chemotherapy. This is one operation where you cannot do it by yourself. If you are the general surgeon, then the plastic surgeon is dependent on you. And then the result is dependent on the radiation oncologist, and the patient depends on all of that. So if you as a surgeon leave the plastic surgeon with flaps that are traumatized, that are irregular, that are ill-perfused, there's nothing he can do. If you leave him with good flaps and he does good job, then still the radiation oncologist may ruin the whole thing. When is the last time you spoke to a plastic surgeon and asked him, which incision do you think is the best incision for this patient with this tumor in that breast? When is the last time the plastic surgeon spoke to the radiation oncologist and said, you know, this is a different reconstruction. Not all reconstructions are the same. You know that radiation oncologists used to think that all reconstructions are the same, and plastic surgeons used to think that all radiation oncologists are the same, and that all radiation oncologist techniques are the same. Well, they're not. And I'll show you some evidence of that. I don't know how we got to this. We need to go back. Let me see. I need some help here. It jumped to the last slide. Maybe it wants me to finish. We're here. Okay. So when you inherit flaps from a general surgeon as a plastic surgeon, you should ask yourself, if you do a reconstruction that is immediate, are you doing a one-stage directly to implant, or are you doing a two-stage? How do you base your decision? Well, until 10 years ago, it was only possible to do a total submuscular tissue expander and then exchange it in a different stage. So it was always, almost always, invariably two stages. Today, you have soft tissue support devices, which we'll talk more about today and tomorrow. They provide strength and take the tension off the implant, any implant, off the soft tissue envelope. They support the implant. They bridge the defect between the cut end of the pectoralis muscle and the inframammary fold, and they reduce the incidence of capsule contracture, as we will see. The problem is that, as with anything, this has its own complication rate. And it has a slightly higher complication rate in one stage than two stage. So you have to have a perfect skin envelope to put a definitive implant with an acellular dermal matrix or a tissue reinforcement matrix. We'll talk about that too in the first operation. What are these surgical meshes? Well, there are human-derived dermices, several. There are mammalian-derived dermises from cows and from pigs. And there is some natural fiber support, tissue reinforcement support matrices that are made out of silk, that are made out of Vicryl, that are made out of PDS, and most all of them are absorbable. I will not speak about anything that is not absorbable, because I think that to put an extra foreign body for a long time in a breast is not a good idea. One foreign body is enough, and that's the implant. These are the 6 tissue reinforcement matrices and acellular dermal matrices that we have had experience in the last 10 years. The advantages of using a tissue reinforcement matrix is that it affords you to do one operation if everything else is perfect. The disadvantage of doing it that you have one shot of choosing the right incision, of doing the fine and delicate and non-traumatized and well-perfused skin flaps. You have one shot at choosing an implant and one shot in closing the wound well. And that has a learning curve which is steep. The first 30 patients are the patient that will suffer most of the complications. You need to go slow on that, and if you want my advice, start always with a 2-stage. Tissue expander first and then exchange it at a later time. To be a good candidate for 1-stage reconstruction, you have to have a skin envelope that is adequate in size to cover the implant that you want to put in that patient, and it has to have an adequate blood supply to do the job. Otherwise, it will break down. There are 2 types of patients that should not have a direct-to-implant 1-stage reconstruction. One is smokers, because of the carbon monoxide and the nicotine are very strong vasoconstrictors, especially on tiny little flaps of the skin. And finally, obese patients with a BMI over 34. You have to select a procedure when you're seeing a patient. Do I do a nipple-sparing mastectomy? Do I do a skin-sparing mastectomy? Do I do a skin-reducing mastectomy? And do I do it in 1-stage or 2-stage? We have built an algorithm to make those decisions. And generally, in small to medium breasts, if you do a nipple-sparing mastectomy on your right, the incision to do is an inframammary fold incision. For a skin-sparing mastectomy, it's usually an oblique incision around the nipple, areola, that goes laterally and oblique onto the upper outer quadrant. Inside, you elevate the pectoralis major muscle off its origin, and then you put an implant in or a tissue expander, and you suture the acellular dermal matrix or the tissue reinforcement matrix to the cut end of the muscle and to the inframammary fold in the lower flap. In large breasts, you have 2 options. Option number 1, to your right, is doing a wise pattern reduction type incision. You can then deepithelialize the skin between the legs of the reduction pattern, base its blood supply on the inframammary fold, and use that as a patient's own cheap acellular dermal matrix. Problem is, it doesn't work. The reason it doesn't work is twofold. A, it has a high incidence of capsule contract, high incidence of flap necrosis on these inverted T incision, and 2, this dermis cannot hold an implant for a long time and it gets settling down on the implant. So instead, on your left, we have developed what we call the transvertical approach, which you'll see more about soon. And to do that, we designed 2 ellipses. One is a horizontal, the other one is a vertical, to reduce the skin and make it safer. What are the factors that influence your decision? The breast size, the breast shape, ptosis or not, the patient preference, the surgeon preference, and the tumor location. For a medium to small breast, that you can do a nipple-sparing mastectomy, the best incision is the inframammary fold incision. For a medium to small breast, where you need to take the nipple away, the best incision is a small ellipse around the nipple, going up laterally or to the upper outer quadrant. The transverse, if you make it small enough and you stay medially to the medial border of the areola, would give you good results. And finally, the transvertical approach, which I'll show you how to do in a minute. This we don't do anymore because we have been disappointed with the perfusion and the poor blood supply to the inverted legs of the T incision, and also been disappointed with the ability of a de-epithelialized dermis to hold an implant long term. So here's how I mark a patient for a transvertical approach. I'm sitting, she's standing. I mark the upper portion of the breast, the medial cleavage of both breasts. I mark the inframammary fold on one side and then on the other side, because when the breast is large and ptosis, very often there is a difference of 1 to 2 centimeters at least. The same applies for the nipple. With the arms up, you want to know where the peak of that pyramid is. And when you compare those, it is here. So it makes sense to mark these, because when the breasts are not there anymore, you don't want one breast to be lower than the other, and you don't want the peak of the pyramid to be in a different place. You can assess, as we will speak more, the volume of the breast preoperatively by using several methods. These are plastic balls that are very simple and very effective in finding out the breast volume preoperatively. I tailor tuck the breast with my finger on a horizontal plane. I draw an ellipse and then another ellipse that is overlapping the first one around the nipple areola complex. The red line is where I'm going to cut, as we will see shortly. These lines are something that I can decide what I want to do with. I can de-epithelialize it and use it to reinforce my closure. I can trim it if the edges are traumatized, or I could use it for other things that I'll show you in a minute. This is the same patient on the operating room. We use this ingenious laser Doppler camera that tells us the perfusion in the skin of the patient, and then we begin our mastectomy. In the next 2 days, you will see some videos on how we do our mastectomies, and as plastic surgeons, they can lift the skin off the face from the facial nerve. Certainly we can lift the skin of the breast off the breast tissue. Once we have done that, we cut on the red line in order to leave some edges that we can trim or de-epithelialize or use later. And then we cut in order to fall into our cavity, because we have lifted the skin flaps before. If you look for a minute at this, Let's see if I can stop here. Let's see how I can do that. You look, the other surgeon on your left, let's go back. Let's see, I don't want to go back. This is this way. Anyhow, maybe I can do it here. There's no anything. Okay. So it depends how you treat those flaps. There are two surgeons working here, and one surgeon is holding the skin flap with his own hand and lets the assistant retract the breast. The other surgeon is holding the breast and lets his assistant hold the skin flaps with an instrument. When you do that, and you take the perfusion of the two skin flaps and exactly at the same time, using a laser Doppler camera, you see that the perfusion on one side is 50% of normal, while the perfusion on the other side is 96% of normal. So it is how you're holding the flaps, you'll see that in a second. It's how you're holding the flaps and how you, here it is. So on the left side, 50% perfusion. On the right side, 96% perfusion, because I am holding the skin flaps with my hand, the way I would like anybody to hold my skin. And the other surgeon is holding the breast. So she's holding what is going to be thrown away or given to pathology, and so on. Anyhow, so at the end of the procedure, this is what we have. We take it out, we weigh it, and we measure, compare it to the preoperative weights of our patients. Let's go down, next one. Okay. What is this acellular dermal matrix? This is a surgimen. It's made out of bovine ADM, cows, actually fetus of cows. And this is at the time that we put it in. And this on your left is when a tissue expander is being exchanged into a definitive implant. And we took two biopsies, one from an area of an ADM, and one from an area with no ADM. And what did we see? This is what we saw. So in the area of no ADM to your right, there is more stuff happening. There's more action. There's more cells. There's more proliferation. There's more blood supply. And that probably means more inflammation. How is that important? It's very important for the formation of capsule contracture. One of the amazing byproducts of using a support matrix to the breast during reconstruction is that the incidence of capsule contracture in breast reconstruction has gone down from 52% to 12.3%. You see that the area of the ADM on your left, there's less cells, there's less stuff happening, there's less proliferation, and we'll see what that means. I want to share with you some examples of nipple-sparing mastectomy, like in this patient, through an IMF incision with a breast weight of 253 grams, and this is her 2 years after direct-to-implant, one operation, a full height, fully projecting implant of 535, so we doubled the weight or the volume of her breast, and an ADM. So she almost looks like she had a breast augmentation, which is not something I would recommend for you to do in the first few times that you use it, because you're putting more stress on the skin, but in her, it was possible. This is another patient with a large breast that weighed 510 grams during mastectomy, with another lateral incision with another surgeon, which was exchanged with a full height, fully projected 535 implant and an acellular dermal matrix, and this is her 5 years later. Interestingly, if you leave the entire skin envelope and you suture the tissue reinforcement matrix in the lower pole, you can get ptosis of the breast to a degree that you don't need to do anything to the other breast, which I think is a big advantage. Or this patient who had a large breast, skin-reducing mastectomy with a transvertical approach, 872 gram, large breast. And here she is with a direct-to-implant, one stage, and an acellular dermal matrix with a full-height, extra-projecting anatomical implant of 615. Interestingly, she went ahead to have radiation therapy. So below is her picture after radiation. Obviously, the radiation has shrunk her skin a bit. She does not have a capsule contracture. But we had to lift the other breast. So this is 2 years after finishing radiation therapy with a mastectomy on her left breast and a finished one-stage reconstruction on the right breast. Well, look at this patient. This is a patient that is a complicated patient for anything. But she also had breast cancer on the right side. So, since she was a BRCA carrier, we did a bilateral mastectomy and an immediate one-stage reconstruction by doing the mastectomy on the right side through an incision that is in the lateral part of the breast, then deepithelializing the portion above the breast, not full thickness, and lifting it up. Or this patient. This patient had a lumpectomy on her right breast, but the margins were involved. So she came to us. When she came to us, we assessed the volume of the left breast, which was 424, using the salad balls and the implant and the Vectra, which is a three-dimensional photography, and found the volume of the right breast to be 363. In mastectomy, when we weighed the breast, it was 350. Knowing the size of her other breast, we put an implant that was very close to the size of her left breast during surgery. And this is her after surgery. This is about 2 months post-op. Now, when you look at her again, you see that she has a ptotic left breast, which we didn't have to address because you can get nice ptosis and a natural breast when you keep the entire skin envelope whenever it is safe oncologically, and add a tissue reinforcement matrix or acellular dermal matrix to the lower pole. Then she went ahead to be irradiated on the right side. So when you look at the change between the pre-radiation above and the after radiation below, and you look at the picture to your right, you can see that the position of the nipple is higher because only the skin has shrunken, but the breast remains soft. So now, after radiation, she has less ptosis on the right side, but she didn't want to touch the left one. For her, it was good enough. Or this patient, who is young, who had a lumpectomy and irradiation 3 years previously on the right side, and now she had a recurrence. So she came back and had a 2-stage reconstruction with an ADM and a tissue expander on the right and an augmentation on the left side. When she came to exchange her tissue expander to a definitive implant, she found out that she was a BRCA carrier. So she asked for a risk-reducing mastectomy on the left side, which we did at the time of exchange. So here you have a patient with 2 breasts. One has been irradiated, has been reconstructed with a simple implant tissue expander and ADM in 2 stages, and one that has been reconstructed in 1 stage. One is radiated, one is not, and they look pretty much the same, which was not possible in the past. So in summary, the factors that you should consider when planning surgery, A, is the specific patient considerations, because patients are different in many, many ways. You should select the procedure and the incision and either an expander or an implant that is specifically suitable to that particular patient, and we'll talk about it some more. Certainly the use of acellular dermal matrices and tissue support matrices has been extremely useful in the surgery of breast reconstruction with implants. You should be aware of the challenges and the traps that are waiting for you in each turn of this procedure in order to reduce complication and enhance the overall results and the patient experience. Thank you very much.